Thank you for this opportunity to tell you a little about the Translate trial. My name is Alastair. I'm a cancer research UK clinician scientist and prostate cancer surgeon, and along with my fellow CRUK clinician scientist Richard Bryant, we're delighted to say we've been funded by NIHR Health Technology Assessment to undertake this important randomized controlled trial. It's always good to have a top-line summary of any presentation, isn't it? So if you remember nothing else, these are the key details. It's an RCT randomizing just over 1,000 men equally to two arms, which compare two LATP devices in one arm versus trus biopsy. The primary outcome is detection of clinically significant prostate cancer. The secondary outcomes are infection, tolerability, and health economics. It was an idea thought up on an RSM ski trip by one of our senior colleagues, and Richard Bryant and I have been given just over 1.5 million to deliver this. But before I continue, I thought it might be helpful to explain some of the context here. What is the problem? Why do we need a trial? Well, perhaps I could just run over what we're trying to do in prostate cancer diagnosis. Here's the prostate here, the pink structure below the bladder and above the rectum. We usually have an MRI that shows an area of suspicion to target, a bit like this encircled red area of low T2 weighted signal here. Well, the standard way to approach this is something called a transrectal biopsy. An ultrasound probe is like this, inserted into the rectum, and biopsies are taken at angles through the lining of the rectum. The problem with this is that it's quite hard to hit the apical lesions because of the angle, and also anterior lesions such as the one shown here, because they're on the other side of the prostate. And of course, this is not a risk-free procedure, particularly given that the area that we're biopsying through is lined with fecal material, and that increases the risk of infection. So what's the alternative? Well, Trans-Perineal Biopsy still involves placement of an ultrasound probe in the back passage, but instead of passing through the bowel lining, the needle instead passes through the perineal skin, the skin between the back passage and the scrotum. And this can be sterilized with surgical preparation. It also allows lesions to be targeted more precisely using a parallel approach in through the apex of the prostate, which can be extended to hit the base of the prostate if needed, or which can be angulated and moved to be able to comfortably hit anterior lesions. And this means that a more comprehensive systematic assessment of the prostate is possible, as well as the ability to hit these anterior MRI visible lesions, or indeed those at the apex. And why the emphasis on LATP, local anesthetic transperineal? Both procedures are performed under local anesthetic after all. Well, Trans-Perineal Biopsy used to only be possible under general anesthetic with a big, complicated stepper system attached to the bed, and it required the patient to be asleep essentially. Whereas these small clip-on devices, which have taken away the need for this big system to be attached to the bed, have made it much more straightforward and possible to be performed under local anesthetic. So back to the trial. All good science must have a hypothesis, whether basic science or clinical. The hypothesis here is that LATP improves detection of clinically significant prostate cancer and decreases infection rates compared to transrectal biopsy, and I've covered most of the aims and the design of the study already. We plan to achieve these aims by conducting a multi-center UK-wide study in England, Scotland, and in Wales, in both teaching hospitals such as here, Edinburgh, Cardiff and Sheffield, as well as smaller DGHs such as Milton Keynes and High Wycombe. There were 9 centres at the start, but it looks likely that North Manchester and some Cardiff DGHs will be joining as well. The trial is intentionally pragmatic. Essentially, anyone coming through the primary diagnostic pathway who needs a biopsy is eligible unless they are immunocompromised, in which case they would need to have an LATP biopsy. So let's look at the PICO. It's an important way, isn't it, to summarize clinical research. The population is 1,042 men who are needing a biopsy. The intervention is LATP using one of the two devices and limiting the number of biopsies to half of what we normally do in order to achieve equivalence with transrectal biopsy, the comparison, which is usually only 12 biopsies compared to the 24 that we often perform currently for LATP biopsy. The primary outcome is detection of clinically significant prostate cancer. After all, a man doesn't come for a biopsy to avoid infection. He comes to know whether or not he has cancer. And the secondary outcomes are several, including infection, quality of life, health economics, and such like. The sample size has been calculated in order to detect a difference of 10% based on published data from large cohort studies for LATP. These two examples being our own papers, but there are several others for LATP and numerous for TRUS biopsies. Of course, there are some exclusion criteria, as you'd expect. I've touched on the main one relating to immunocompromise and infection, but also men with very high PSA will be excluded due to the futility of trying to detect a difference in the primary outcome in these men. And the timelines of the trial are laid out here. We started last month with the appointment of our trial manager, Roxanne Williams, who's doing an absolutely superb job of building momentum to get the trial open to recruitment, hopefully before the deadline in October. We hope to recruit on, if not ahead of time, as long as vaccines continue to work and COVID doesn't return. Trials work in different ways. Some mandate a feasibility study to ensure that randomization is possible. In our case, we have built in a 6-month pilot phase, after which there will be a stop-go decision point. Most of these centers perform almost exclusively transrectal TRUS biopsy at present, and have only just started offering LATP. So we don't anticipate any big problems with recruitment, but you never know. To finish, what's the potential impact of this? Well, if we look UK-wide, there are approximately 70,000 biopsies performed per year in the UK, of which the vast majority are transrectal. Based on our hypothesis, this means 6,000 incorrectly diagnosed patients each year. And based on a conservative estimate of the difference in sepsis rates, this means 1,200 more hospital admissions for sepsis. And of course, globally, the numbers are huge, and therefore the impact of this trial, whatever we find, is likely to be far-reaching. But remember, our estimates are based on a hypothesis. We need to test that hypothesis with quality science to deliver the evidence to show whether these hypotheses are true. We have a big team, as you can imagine, from the centre leads to the TMG here in Oxford, and our esteemed steering committee and data safety monitoring committee, to all of whom we are, of course, very grateful. Thank you very much for listening. I think we may now have some time for live questions.